Just a few seconds to go.
सर मैं स्टार्ट करूं?
एक मिनट. Just a few seconds to go. Right. So now it is on YouTube. So any number of people can join. There are almost 50 people right now here. So you please start. You can make it on full and start it. And if you find yourself muted, then you unmute yourself, because it is you are the only person who can unmute yourself. Please start.
Okay, sir. So, good evening to all those who are listening to this PGNAR, and it's a real pleasure to be here on this platform. And I'm really thankful to Dr. Dinesh Mathur for giving me this opportunity to interact with you guys today. So the topic that I'll be speaking on today is alopecia areata. So this is how the topic will be discussed. We'll be discussing about the definition of alopecia areata, the epidemiology of the disease, the etiopathogenesis of alopecia areata, then clinical presentation and scoring of alopecia areata, disease course and prognosis, and management. So, and then I'll talk about some new treatment options and recent advances in alopecia areata. So what is alopecia areata? It is basically defined as a chronic, and I'll stress on this word, recurrent, non-scarring alopecia. So remember this word recurrent. Alopecia areata is more often than not recurrent. And it's the second commonest cause of hair loss after androgenic alopecia. And it is thought to be autoimmune in origin. It can involve any site of the body, but scalp is the commonest site that is affected. Alopecia areata is a very common disorder. It has a lifetime prevalence of 1.7%. That means around 2% of people in the world develop alopecia areata anytime in their lifespan. It's the commonest cause of inflammatory hair loss. It involves both sexes and all age groups. And remember that most patients are relatively young. So the peak age of onset of alopecia areata is between 20 to 40 years. And about 2/3 of patients of alopecia areata are younger than 30 years of age, and only 20% are older than 40 years of age. And some studies, they report a male preponderance, and some studies have shown that disease is more severe in males than in females. What is the pathogenesis of this disease? Alopecia areata, in a nutshell, is considered to be a T cell mediated autoimmune disorder. And to understand the pathogenesis of alopecia areata, it is important to know that this the important immunological feature of hair follicle is what is known as the relative immune privilege of the hair follicle. What does that mean? Is that any interfollicular pathology in the skin is unlikely to affect the hair follicle per se because of a relative immune privilege. And this relative immune privilege is established by two things. One, suppression of surface molecules that are required for presenting autoantigens to CD8 positive T lymphocytes. So there is a suppression of the surface molecules that are required for presenting autoantigens, and there is a generation of an overall immunoinhibitory local signaling milieu. Now, this downregulation of MHC class 1 molecules, however, entails the risk that the hair follicle may be attacked by natural killer cells, because natural killer cells, as we know, they can recognize and eliminate MHC class 1 negative cells. So they don't need that binding to MHC class antigens. And to reduce this risk, healthy hair follicles appear to downregulate the expression of ligands that stimulate natural killers activation and natural killer cell receptors. And they secrete molecules that inhibit natural killer cells as well as T cell functions. Now, what happens in alopecia areata is that there is a collapse of this immune privilege zone. And how this happens is not known. So there is an auto antigen that is unknown, which leads to collapse of this immune privilege zone. And that leads to an immune mediated damage to the hair follicular cells. So interferon gamma and interleukin 2, they induce infiltration of CD8 positive, CD4 positive T lymphocytes and other inflammatory cells into the immune privilege zone. What are the etiological factors of alopecia areata? One is the genetic factors. So around 10 to 42% of patients of alopecia areata have a positive family history. And the genetic locus that has the highest association with alopecia areata is the HLA-DR locus on chromosome 6. These HLA class 2 genes are linked to CD4 as well as CD8 positive T cells, which are highly relevant cells in alopecia areata. There are some other loci, genetic loci that are implicated, like the BCL2 like protein 11, also known as BIM, which helps to regulate autophagy in the disease pathogenesis. And then genes encoding for natural killer cells and receptor D ligands and downstream effectors of the JAK pathway. And then genes for T regulatory cells or TREGs, autophagy, and apoptosis. So these are the different genetic loci that have been associated with alopecia areata. Then there are some environmental factors like infections. There are some viral infections that are implicated. Then vaccinations, hormonal factors, diet, and a recent interesting addition to this list is the microbiome. And this microbiome includes both cutaneous as well as the gut microbiome. So an interesting feature in alopecia areata at times we see is that more than one family member is involved at the same time or within some time, and people feel that it can be because of some link with the microbiome. Then other factors implicated are stress, and this is considered to be the most important and the most cited risk factor for alopecia areata. And this is how alopecia areata develops. So this is on the left side of the screen. You can see a normal hair cycle of anagen, catagen, telogen, and then the return to anagen. And this is how the disease process develops in alopecia areata. So there is infiltration of natural killer cells, CD8 positive T cells, CD4 positive T cells, and there is some relation with mast cells also. And that leads to premature induction of catagen and resultant hair loss. Clinical presentation of alopecia areata. We all know that alopecia areata is a very common disease and we can diagnose it quite easily. It's characterized by well circumscribed patches of alopecia with normal appearing skin most commonly seen on the scalp and in the region of the beard. Onset is typically rapid, and it can start as a single patch or as multiple patches together on scalp or beard, and it can sometimes start and remain localized to eyebrows or eyelashes only without involving the scalp or the beard area. So you can have alopecia areata limited to these areas like the eyebrows or eyelashes only. And sometimes it can even start as a diffuse hair loss. So any patient with acute onset of diffuse hair loss, you have to exclude alopecia areata and look for any signs of alopecia areata on examination as well as on trichoscopy. Course of alopecia areata is hugely variable and unpredictable. This we'll be discussing later also once we discuss the natural course of alopecia areata. There are different patterns of alopecia areata. If there is a single patch, then we call it as a focal alopecia areata. And then there can be multifocal involvement. Then can be a pattern known as ophiasis. Then the reverse of ophiasis, which is known as the Cephalpo pattern. Then there can be a diffuse alopecia areata, and an uncommon variant of alopecia areata is known as alopecia areata incognita, which is very difficult to diagnose on clinical examination. So these are the different presentations of alopecia areata. On the left-hand side, you can see a picture in which there is involvement of the margins of the scalp from the occipital as well as the parietal area, and this is known as ophiasis pattern. And on the right-hand side, you can see a multifocal alopecia areata involving the scalp. And these are two photographs which denote alopecia areata. On the left hand side, you can see a young girl in whom the alopecia areata is limited to the eyebrows only. And on the right hand side, you have one patient in whom you have eyebrows, eyelashes, as well as mustache involvement with alopecia areata. Now, remember that alopecia areata severity varies quite considerably. It can vary from a single episode of self-limiting focal or patchy alopecia to a non-responsive progressive hair loss, which can involve the whole scalp. Uh, the term that we use there is known as alopecia totalis, or even the whole body, and wherein we use the term alopecia universalis. Now, some examples of alopecia totalis. You can see the male with total loss of scalp hair, and this is alopecia totalis. And then there is a photograph of a female in whom the scalp as well as the body hair is involved, and that is known as alopecia universalis. How does alopecia areata involve different body sites? Remember that scalp is the commonest site of involvement. And in the scalp, the commonest site that is involved is the occipital region. And upon first presentation, more than half of adult patients had patchy hair loss with less than half the scalp involved. And scalp involvement alone accounts for 48% of all cases, followed by beard hair alone in 21% and eyebrow alone in around 4% cases. In the rest of cases, multiple areas of the body are involved with alopecia areata. This is something really important and something that we need to consider, that scalp involvement alone just accounts for 48% of all cases. That means more than half of the cases will have involvement of areas other than the scalp. This is something important, and this is something that is important in calculating the severity, which I will discuss later in the lecture today. Nail changes occur in around 10.5 to 38% cases of alopecia areata, and the commonest findings that we see include pitting, tracheonychia, and longitudinal ridging. And nail changes are associated with disease severity. So more severe alopecia areata, more the chances of nail changes that we see. Diagnosis of alopecia areata is made on the basis of clinical examination. So we just have to look at the skin on the scalp or other body areas, and what we see is loss of hair with normal appearing skin. Uh, but it is very important as a clinician to look at the skin quite closely and look for any evidence of atrophy, because it is at times very difficult to differentiate alopecia areata from pseudopalate of Brock or even lichen planus. And my experience tells me a lot of dermatologists, they go on to miss that mild atrophy in early cases. And that is very important because the prognosis is different. If you have lichen planus or pseudopalate, the prognosis is different from that of alopecia areata. And it's important to recognize atrophic alopecia as early as possible to prevent its progression. Trichoscopy is of great help in the diagnosis of alopecia areata. And if you have a doubt, especially in cases with alopecia areata incognita or diffuse variant of alopecia areata, you can take a biopsy of the follicles. And this is a histopathological picture of a typical alopecia areata hair follicle. And this picture is known as swarm of bees appearance. That would mean that there are a lot of inflammatory cells, especially lymphocytes, around the hair follicle in the center. Uh, Typical trichoscopic features of alopecia areata that we see are the black dots, the yellow dots, empty follicles, white dots, micro exclamation mark hair, codability hair, and broken hair. So these trichoscopic features are important in the diagnosis as well as in the prognosis of alopecia areata, because many of these trichoscopic findings uh, tell us whether the disease is active or not. So once we start treating a patient and you see that there is a change in the trichoscopic features, you can safely assume that the patient has gone into remission even in absence of a visible hair regrowth. So these are typical black dots that we see in alopecia areata on trichoscopy. And then the yellow dots on the left-hand side and exclamation mark hair that is there with designated by the arrow, the black arrow. So you can see that the top of the hair is broader and it tapers down towards the surface of the scalp. That is a typical exclamation mark hair. Now, very important to realize, and I think many of us miss this part of alopecia areata, is what is the natural history or progress of alopecia areata. There are some studies that have been done, and this is one of the study, large study on alopecia areata, which said that the duration of initial attack is around less than 6 months in around 33% cases, less than 1 year in 50%. But this initial attack, 33% cases did not recover at all from the acute attack. Now, this is something really important and something really concerning for us as dermatologists, is that incidence of relapse in this study that was done, the long-term study, was 86%. That is why I told you in the initial definition of alopecia areata that alopecia areata is defined as a chronic recurrent cause of alopecia. And of those cases who developed alopecia areata before puberty, 50% eventually became totally bald. In contrast, only 25% of those who developed disease after puberty became totally bald. So onset of the disease is very important. Persons in whom the disease starts early have a worse prognosis. And from Mayo Clinic, only 1% of children and 10% of adults with alopecia totalis showed complete regrowth. In no case of alopecia areata is a complete confident prognosis justifiable. This is something written in Rook's textbook. And alopecia areata in atopic state has a poor prognosis than in non-atopics. So this is a study, and this was published in JAD, and it's a mean follow-up of 17.4 years. So you can now see that recurrence as well as progression of disease of it is really, really common. So these are different S0, S1, S2, and S3. These are different stages in the scoring of alopecia areata. And what does this mean? This means that the dictum that majority of alopecia areata patients don't need any treatment, that is what initially used to be taught, it does not hold true. Alopecia areata needs to be treated and patients need to be monitored closely and regularly to look for disease progression. And the most important prognostic factor is the extent of hair loss. The larger the area of hair loss, the poorer the treatment response and greater the probability of chronic disease progression. The prognosis is less favorable with nail changes or atopic disease, and if the disease starts at a younger age, or if the disease is associated with any autoimmune process. And treatment in alopecia areata should ideally be done as early as possible. Remember, in alopecia areata, the potential for full regrowth is approximately 50% at 1 year. So if you start treating patients within the first year, 50% can attain full regrowth, and it decreases to 9% at 2 years and 5% at 3 years. And at 5 years, the potential for full regrowth is just 2%. How is alopecia areata assessed? How do we score or how do we assess the severity of alopecia areata? So the commonest score that has been employed in all clinical studies till date is the severity of alopecia tools, or the SALT score that it is commonly known as. It's basically a quantitative method of assessment of scalp hair loss. The whole scalp is divided into 4 parts. The top, which is around 40% of the scalp surface area. The posterior is 24%. The right side is 18%. Left side is 18%. And then we calculate the percentage of hair loss in each area. And then we multiply the area by the indicator of that area. And then we add the different scores, and that gives the total SALT score. So this is how that is done. So you can see that the top is the 40% of scalp surface, left side is 18%, right side is 18%, and back is 24%. So there is an example that is given in the picture above. So the top is around 70% involved, so it gets a score of 28. The back is around 90% involved, gets a score of 22. Left side gets 17, right side gets 17, and the total score is 84. 84% of total scalp surface is thus involved. Another score that is there is known as alopecia density and extension score, or Alodex score. It combines both the extent and hair density into an overall percentage scalp hair loss. And although it is possible to calculate by paper scoring, an iPad app makes it possible to score all the 1% areas quickly and to generate electronically the total Alodex score. Another scoring that is described in alopecia areata is the alopecia areata progressive index. This was introduced in 2016. So how this method differentiates from others is that it includes the activity of hair loss. See, SALT score tells us what's the extent of hair loss that the patient has. It does not tell us whether the disease is active or inactive. So this score adds that activity into the overall scoring. And SALT score from each quadrant is multiplied as is done in the SALT scoring. And then the activity is also added. And this activity score is based on the hair pull test as well as the dermatoscopic findings of exclamation point hairs, broken hairs, and black dots. And sum of the products from each quadrant of scalp gives the total AAPI score. Then there is the SBN classification of alopecia areata, and this was something that was there in the table. So S0 means no hair loss, S1 means around 24% hair loss, 1 to 24%. S2 is once you have 25 to 49% hair loss of the scalp. S3 is once you have 50 to 74%. S4 is 75 to 99%. And then S4 is further divided into S4A, 75 to 90%, S4B is 91 to 99%, S5 is 100% hair loss or alopecia totalis. And then body, B0 for no body hair loss, B1 for some body hair loss, B2 for total body hair loss. And then your nail involvement, N0, all 20 nails, N do not show any pitting or trichonychia. N1 is some of the nails show these changes, and N2 is all 20 nails show pitting or trichonychia. So that gives the total SBN classification of alopecia areata. Now, something interesting in these scoring systems that I would like to stress upon in this lecture today is that if you have really gone through these scoring systems and understood them, these scoring systems do not take into account the involvement of cosmetically important areas like the beard hair, eyebrows, eyelashes. If you talk about SALT score, you talk about Alodex score, you talk about SBN classification, none of these scoring systems give any importance to beard hair or eyebrows or eyelashes. While scalp hair loss is calculated in detail, there is no importance given to eyebrows, eyelashes, and beard hair. And we all know that eyebrows, eyelashes, and beard hair in men are cosmetically as important or even more important than scalp hair. And eyebrows and eyelashes are important in females as well, and probably more important than even scalp hair. With this in mind, we have proposed a new scoring system in alopecia areata, and this uh, score is known as AASI score. Now, how do I explain that score? Is look at this picture on the left side of the screen. This, uh, these two cases. Now, these two cases have involvement of beard hair, but the scalp is not involved. Now, if we take any of these scoring systems that we have, like the SALT score, the SBN score, or even Alodex score, so none of these scoring systems can really tell us the extent or the severity of alopecia areata in any of these cases, or in a female who has involvement of the eyebrows. You can see this female who has used a marker to mark her eyebrows because she has lost her eyebrows. So there is no scoring system right now which can assess the severity of alopecia areata on these areas, any of these areas. So what basically is the limitation is that all these scoring systems that we presently use, they give importance mainly to scalp. But as we all know from different studies that I have quoted earlier also, that more than 50% of cases of alopecia areata have involvement of areas beyond the scalp as well. So those cases we are not able to assess the severity or assess the treatment response. To take care of these limitations of SALT score and other scores for alopecia areata, we have proposed a new score and we call this as alopecia areata severity index. This scoring is already accepted for publication in Journal of Cosmetic Dermatology, and this is getting published within a very short time. So how do we do this scoring is that we basically assess three areas of the body, the scalp, and we give a score of 100 as we use in SALT scoring. Then we assess the upper face, that means the eyebrows and eyelashes, and we give a total score of 50 to these areas. And then we assess the beard area. And for beard and mustache, we give a total score of 100. So for face, maximum score of 150 is there in males because that will include both beard and mustache. And in females, the total score for face is 50 because in them the beard is not important. So the total score thus in males comes out around 250. That means 100 for scalp, 100 for face, the beard area, and 50 for the upper face. And in females, 250 as only scalp and eyebrows, eyelashes are scored. But this is how we score the face in alopecia areata severity index. So for beard area, it is 100 into percentage area involved. For eyebrows, 30 into percent area involved. Eyelashes, 20 into percentage area involved. And then score of each area is calculated and then added to give the total score for face. And as said earlier, total possible score is 150 or 15 females. And then we add the scores for scalp, upper face, and beard mustache, and that gives the total AASI, Alopecia Areata Severity Index. So this comes out to be the score for scalp, the score for upper face, and score for beard. For females, score for scalp and score for upper face is added. After the assessment of alopecia areata, we now come to the management of alopecia areata. So, what are the goals of management of alopecia areata? One is to stop the progression if the disease is progressive and to regrow hair. And second important uh, consideration is to prevent recurrences. This is again something that we have to keep in mind because recurrences are very, very common in alopecia areata. So what are the typical treatments that we have? We have topical treatments like topical corticosteroids, we have topical irritants, we have topical minoxidil, topical diethranol, topical vitamin D analogs, topical calcineurin inhibitors. Then we have topical latanoprost, and the importance of this latanoprost or bimetoprost is that it's the only topical agent that we can use in eyelash alopecia areata because this is something that is safer for that area. Then we have topical 5-FU, and then recently topical JAK inhibitors like ruxolitinib is also used in alopecia areata. After the topical treatments, we have intradermal steroid injections that are very commonly used in alopecia areata. And for this treatment, what we need to remember is that this intralesional steroid injection has to be strictly intradermal to minimize the risk of atrophy. A solitary patch of alopecia areata is best initially treated with 2.5 to 5 milligram per ml of triamcinolone and should not be more than 10 milligram per ml and has to be used in small aliquots. Caution is required near the frontal hairline due to increased risk of atrophy. So if the frontal hairline is involved, be very cautious in using intralesional steroid injections. And ideally, you should not use more than zero point 0.1 ml of this intralesional steroid injection at one site, and you should inject 1 centimeter apart into the dermis. So where you should inject where you feel that the disease is the most active. So you should inject it where you have exclamation mark hairs or where you have positive hair pull test or black dots. You can even inject the entire patch, or Some people say that you can inject all the margins of the hair loss patch, and that can even prevent progression of this patch. Uh, Next treatment option that is used is contact immunotherapy. This is one of the well-established treatment options for alopecia areata, and we know the two agents are used. One is DPCP, and the second is stearic acid dibutyl ester. This treatment is effective in patchy alopecia areata and also in some cases of alopecia totalis. There are two phases of treatment: contact sensitization followed by maintenance treatment. So, what have studies shown? Studies have shown that contact immunotherapy is effective in around 60% cases, and it can be combined with systemic treatment options. But remember again, recurrences can occur even after contact immunotherapy, and not all patients can be sensitized. And the healthcare professional who is using this immunotherapy can get sensitized. So it's very important to use proper gloves and while you're using this treatment on any patient, and it can lead to allergic contact dermatitis as well as irritant contact dermatitis. Phototherapy is also used in alopecia areata, and we can use PUVA and PUVA sol. The effectiveness of PUVA and PUVA sol is thought to be due to local immunological attack through depletion of Langerhans cells. Disadvantages of PUVA and PUVA sol include burns, increased risk of skin cancer, and high relapse rate. You can use narrowband ultraviolet B therapy in alopecia areata, and again it acts through immunomodulation by causing T cell apoptosis, as it does with vitiligo and other immune-mediated diseases. You can use UVB combs if you have scalp involvement, and they can be used at home. You can even use narrowband UVB chambers, and it is usually used in combination with any topical or systemic agent. There are some other forms of phototherapy that are used, like excimer laser, excimer light, and they are therapeutically much more effective than narrowband UVB or PUVA. They lead to regrowth of hair in good percentage of cases. They can be used in combination with topicals as well as systemic agents, and the adverse effects include burns and hyperpigmentation. There are some reports of bath PUVA and turban PUVA, which is also used in alopecia area. And then next it comes the systemic treatment options, and these include systemic steroids, sulfasalazine, methotrexate, azathioprine, cyclosporin, and JAK inhibitors. So systemic therapies we use in those cases who have a progressive disease and who are not responding to topical treatment options. Remember that none of these treatment options is universally effective in alopecia areata, and many of these treatment options have significant long-term toxicity. So that is something that we need to remember. Systemic steroids in alopecia areata are appropriate for treatment of severe alopecia areata in adolescents 13 to 18 years or for adults. So they are not recommended in children. The initial dose of prednisolone may be zero point 0.4 to 6.6 milligrams per kg per day, with gradual taper over 12 weeks. And to achieve durable remission in adults, you can use prednisolone for more than 12 weeks as well. Another form of giving systemic steroids that we use very commonly in India is the oral mini pulse therapy, or OMP. So we use either betamethasone or methylprednisolone on 2 consecutive Ks every week, and we can use oral mini pulse for a longer duration than daily steroids because of a relatively better safety profile than daily steroids, and you can use them for 4 to 6 months. And again, remember that you have to gradually taper the dose and then stop. Don't stop them abruptly because there is a high chance of recurrence. And oral mini pulse, the other advantage is it can be given in children also as well as adults. and it is recommended more in acute alopecia areata than in chronic alopecia areata. Adverse effects of oral mini pulse include weight gain and osteoporosis. JAK inhibitors are something that are quite exciting treatment options in many cutaneous diseases, including vitiligo and alopecia areata. These are the two main diseases wherein we use it the most often, in addition to psoriasis as well. So JAK inhibitors basically are drugs which are classified under the broad group of small molecules, and they have been found quite effective in severe cases of alopecia areata, including alopecia totalis and alopecia universalis. So, how do they act in alopecia areata is that involvement of the JAK signal transducer and activator of transcription JAK STAT pathway in alopecia areata, as well as the reversal of alopecia areata with JAK inhibitors, was first demonstrated in mice in 2014. JAK inhibitors, they work on the JAK STAT pathway. The basis for their use stems from the understanding of JAK protein kinase pathways implicated in alopecia areata, which work as downstream effectors of the interferon gamma and gamma C cytokine receptors. In alopecia areata, JAK-STAT inhibition interferes with the positive feedback loop between follicular cells and the cytotoxic CD8 positive or natural killer cells. Clinical studies on JAK inhibitors. So there are several cohort studies and case reports that have demonstrated the efficacy of oral and topical JAK inhibitors. And most patients in these studies, they achieved clinically significant hair regrowth. A meta-analysis of much of the evidence to date has shown oral JAK inhibitors to be associated with better treatment response than topical therapy, regardless of the agent used. And the agent that we use in India is tofacitinib, and the dose is 5 milligrams twice daily. Remember that drug has to be continued for a long time, at least 6 to 12 months. And the most important limiting factor again is relapse after withdrawal. And if you are giving this drug to these patients of alopecia areata, remember that you have to monitor CBC, LFT, KFT, and lipid profile. Hydroxychloroquine is also a very exciting drug in alopecia areata treatment. So it is used routinely by us in many diseases. And this drug has shown some effect in alopecia areata as well. So how does it act? It basically blocks class 2 associated antigen presentation, affecting the function of dendritic cells and macrophages. It has an inhibitory effect on many cytokines and inhibitory effect on toll-like receptors, phospholipase A2 and others. So these are some studies that have shown that hydroxychloroquine is effective in treatment of extensive alopecia areata. Another study and some photographs from these studies that have been published. 9 patients, 4 non-responders, 5 responders, and significant SALT score reduction. We have used hydroxychloroquine here in our center, and we have shown also that this drug is effective in cases with severe alopecia areata. Some cases that we have treated with hydroxychloroquine. So you can get decent results, but again, as with other drugs, this drug is also not universally effective. Some patients do respond, but some patients do not. Then you have procedural treatments for alopecia areata, which include the platelet-rich plasma or PRP. There are few studies and case reports that favor the use of PRP for treatment of alopecia areata. And the evidence as of now is that we need large-scale studies to evaluate the efficacy and to devise a protocol for PRP in alopecia areata. Then you have fractional lasers, which have been used as monotherapy as well as in combination with triamcinolone spray for resistant alopecia areata. How do these lasers act? They act on two fronts. They induce injury with resultant healing response, and then they can assist the drug delivery, which is known as fractional laser assisted drug delivery. So this is something that we tried in combination with topical corticosteroid application in resistant alopecia areata. This was published in JCS in 2018. So what we felt was that if we use a fractional laser treatment and then spray triamcinolone after the laser treatment, so the whole procedure becomes less painful than injections, and you can tackle a larger area in each session. So what are the conclusions and take-home messages from this presentation and this lecture is that alopecia areata is a very common hair disorder. And as I stressed many times in my presentation, recurrence is very common in this disease, especially if onset is earlier in life. Alopecia areata should be treated early, and each patient should be monitored for disease progression. Any patient with progressive disease should be treated with a proper immunomodulator to stop disease progression as early as possible. It is important to treat the patient in the first year of the disease and don't wait for the disease to remain there for more than a year or 2 years. JAK inhibitors and hydroxychloroquine are new agents showing promise in alopecia areata. And remember that both these drugs have to be continued for a long time of at least 6 to 12 months to see the response. Thank you so much. And it was a pleasure interacting with you guys and speaking today on this platform. Thank you. Thanks you. Thank you once again.
Thank you very much, Imran. It was indeed a very good thing. And before we take up the questions in the chat box and other thing, the people were asking about the doses of hydroxychloroquine. Can you listen me? Hydroxychloroquine, as well as the JAK-STAT inhibitors. JAK-STAT inhibitors, the topical formulation, in what percentage do you use?
Sir, can you repeat, sir? Can you repeat the question, please?
Number one, what are the dosage schedule of hydroxychloroquine and for how much time? And number two, what percentage of the topical tofacitinib you have used? I have tried around 1%, and it has given me good results, but in few patients.
Uh, Sir, number one, dosage of hydroxychloroquine. The dosage we use in other diseases like 0.6 milligrams per kg and maximum of 400 milligrams per day. Duration, as I said, is at least 6 to 12 months. I usually taper after 6 months, and then I try to taper the dose according to the response that the patient is showing.
But you keep on
Uh,
getting eye
and
examination and everything, retinal examination and all these things.
can you repeat, please?
You go for the eye examination for the safety of the patient.
Yes, yes, that is something that you have to do. As you do with hydroxychloroquine, any other indication,
Right.
you have to do that. That is for sure. And topical JAK inhibitors, I have not used. They are not available here with me, and I have not used topical. But yes,
But
I have used oral JAK inhibitors.
they and how is the result? Because I have used, I made topical formulation of 1%. It costs around around 1,200 to 1,500 rupees. The actual cost of the tablets.
Right.
And it gives a result in 2 to 3 weeks. Patients are comfortable. I have used this MEL also, but could not. I have used fractional CO2 also, but not very comfortable and not very good response in that. Neither MEL. MEL, of course, cost a bit more. It's not cost effective. Monoexcimer laser.
Right.
Dr. Lalit, can you please comment from Dr. Niranjan Nagpur, sir?
Sir, आप muted हो, muted हो.
Right, right. No, no. Sorry. Now, please unmute yourself.
Yeah, okay. Well, it's a very, very good lecture. So it's completely, right from the etiological factor and classification, everything is very nice. So it's a very good revision for us. Very good revision for us. And the only thing which I learned is the hydroxychloroquine is a new thing which I
Right.
didn't know about.
I also learned the same thing.
Yeah, so that's a good thing. So because that is better than maybe JAK inhibitors and
Yes.
methotrexate.
Safety, sir, safety wise, this drug is
And
definitely
may
safer.
save from corona also.
Yeah.
Yeah, that's right. The another thing, Dr. Majid, what I wanted to ask you is, you know what, the lesions on the scalp area, especially on the occipital region, the response to the treatment is very good as compared to the lesions on the beard area. What is the reason for that?
As compared with lesions on which area?
Beard area.
Beard
Beard
area.
very difficult to treat.
Yeah, true, absolutely. Beard area, I think, responds less and responds late than scalp hair. What is the exact reason? I don't know, but yes, this is my experience as well. And something that regarding beard, if you are using something that's a very important therapeutic point is that if you are using triamcinolone injections on beard, be very cautious. Use lower concentration of triamcinolone. That's very important.
The other thing is, if you are treating with hydroxychloroquine, do you add along with the minoxidil also topically?
Yes, sir. I do use topical treatments along with hydroxychloroquine. Yes, you can use any topical treatment.
Lalit,
there is one question that I can see on the chat is treatment preferred for eyebrow and eyelash loss. I'll share my experience and I'll request others also to share their experiences about this. I think for eyebrows, you can use topical steroids, relatively less potent topical steroids. You can use bimetoprost, and you can even use low concentrations of intralesional steroids. Eyelashes, very difficult. You can't use anything except prostaglandin analogs, and you can't use anything else there because whatever you use on the eyelashes is going to go into the eyes. So you have to be very cautious with topical treatments. So something very difficult to treat, eyelash alopecia areata. I would like others, Tata Dinesh and others also to opine on how do you treat eyelash alopecia areata.
Well, that only one thing is available which is being used and pretty expensive, bimetoprost.
But you know what percent of patients will have improvement with the bimetoprost or whatever it is?
But that's the only thing which we have got in our country to offer. That is the only thing.
We can try it out.
So probably if we combine a topical bimetoprost with some oral agent, see, my take on alopecia areata is that this disease needs to be treated early and needs to be treated seriously. So maybe you can use some oral treatment as well, even if you have alopecia areata limited to eyelashes, if it is causing a real psychological distress to the patient.
The other treatment is very difficult to treat is uffiasis and cyphopia. They don't usually respond to treatment at all.
Exactly. It's very difficult to treat. True.
Well, Dr. Shwetal wants to ask why there is a sparing of gray hair getting alopecia areata, and can regrowing hair be depigmented, and when they can become normally pigmented? At least I have not seen anything getting repigmented. It's a matter of chance.
White hair is considered to be resistant to alopecia areata because the antigen that is responsible has to do something about it. So the antigen that is there, that is in the hair follicle, that antigen is not so much expressed in white hair as it is there in the black hair. That is something that I had learned many years back, and I don't exactly remember the name of that antigen. So that is why white hair is relatively resistant to alopecia areata as compared to black hair.
And then she wants to ask why there is a geometric pitting in alopecia areata.
There is another question, sir. Which option to consider in patient of alopecia areata scalp, 52 male, having active lesions while on oral minipulse and ILS? First dose of Covishield taken 10 days back. Okay. I think a very nice option in this case would be hydroxychloroquine. It would be something that will not interfere with the immune response. And you can even add this to oral mini pulse or use it as a monotherapy also.
I think probably you should try this and steroid together. We need.
Well, thank you very much. Since we have dealt all the questions, and it was a nice meeting. And thank you very much, Dr. Imran. And there were some technical problems at your end. We were not seeing your presentation properly. So I discussed it with the technical people, and that was something beyond control right at this moment. Anyway, thank you very much for the nice lecture, and thank you very much all.
Thank you so
Thank you.
much.
Right,
Dinesh.
right, sir. Right, sir. Thank you, sir. So I'm ending the meeting.